In the first lecture in this series, I laid out the basic relationship between behavior and well-being, suggesting that many of the behaviors we adopt, both in our youth and as adults, have a direct effect on our well-being. In closing that presentation, I asked you to consider how we should define the concept of behavior. As the next step towards gaining a deeper understanding of the ways in which behavior affects well-being, it will be important to address the other half of this association by trying to delineate what we mean by well-being. In the United States, the Center for Disease Control and Prevention, often referred to simply as the CDC, is the principal federal agency charged with tracking and reporting the well-being of the U.S. population. In doing this, the CDC has adopted a broad concept of well-being. As described by the CDC, there is no consensus around a single definition of well-being, but there is a general agreement that, at minimum, well-being includes the presence of positive emotions and moods, for example, contentment and happiness, the absence of negative emotions, for example, depression and anxiety, satisfaction with life, fulfillment, and positive functioning. The CDC goes on to enumerate several different aspects of well-being, including physical well-being, development and activity level, social well-being, emotional well-being, psychological well-being, and economic well-being. In this presentation, I would like to look at research on various measures of physical well-being. In the presentation that follows, I will look at how behaviors affect development and activity and social well-being. In comparing the health of societies or other social groups, one of the most frequently cited measures of physical health is life expectancy. Life expectancy can be measured at various times throughout the lifespan and addresses the question, on average, how many additional years will a person who has reached a certain age live? The earliest measure of life expectancy is life expectancy at birth, which estimates how many years on average a baby born in a certain time period will live. As reported by the CDC, in 2010, a male baby born in the U.S. could expect to live 76.2 years, while a girl baby could expect to live 81 years. We should note that life expectancy is reported separately for boys and for girls, as girls live several years longer than boys on average. This brings up the interesting question of what factor or factors explain the consistent advantage girls have over boys in life expectancy at birth. Part of the gender difference in life expectancy can be explained by the hormonal differences that are a consequence of having either one X chromosome and one Y chromosome for male sex, or two X chromosomes for female sex. The different sex hormones that are produced as a consequence of these genetic differences have differential effects on many organ systems and diseases. An additional part of the difference can be explained by differing patterns of behavior that develop during adolescence and early adulthood. For example, in 2010, the age-adjusted death rate per 100,000 population from motor vehicle accidents for those between the ages of 15 and 24 was 23.1 for men and 9.9 for women. What about behavior as adults? Are there consistent gender patterns that could account in part for this difference in life expectancy? If we look at deaths from narcotic drug overdose for those between 25 and 34 years of age, we see that a male death rate of 25 and a female death rate of 11.9. These gender-based differences in death rates among adolescents and young adults have little to do with X versus Y chromosomes and everything to do with gender-based differences in behavior. An important contributor to observed differences in life expectancy at birth is the rate at which infants die before they reach the age of 1 year. Infant mortality rates are reported as deaths per 1,000 live births. As chromosome-based physiologic differences have little impact on the chances of death before age 1, infant mortality rates usually are not reported based on the sex of the baby. More typically, they are reported based on the demographic characteristics of the mother. In 2010, in the United States, the overall infant mortality rate was 6.1. If we compare our national rate of infant mortality to the other developed countries in the OECD, the Organization for Economic Cooperation and Development, we will see that in 2010, out of all the 34 member countries, we ranked 31st. The only OECD countries that had higher rates of infant mortality than the U.S. were Chile, Turkey, and Mexico. As compared to the U.S. rate of 6.1 deaths per 1,000 births, the lowest rates in the OECD were found in Iceland, Finland, and Japan. The infant mortality rate in the U.S. varies substantially based on the race and ethnicity of the mother. We will compare these rates in an upcoming lecture on social inequality and well-being. Giving birth prematurely, typically measured as before completing 37 weeks of pregnancy, is a known risk factor for subsequent infant death. Infants born before 32 weeks of pregnancy are considered very preterm, and those born before 25 weeks are extremely preterm. The greater the level of prematurity, the higher the risk of infant death. Professor Janelle Sparks, a demographer at the University of Texas, undertook a study that compared mothers of different racial and ethnic groups in the factors associated with an increased risk of giving birth prematurely. She found that behavioral differences on the part of the mother, rather than the mother's race or ethnicity, were the principal factors associated with premature birth. Principal among these at-risk behaviors for the mother were giving birth before the age of 20, not finishing high school, being unmarried at the time of birth, and gaining excess weight during pregnancy. Based on these conclusions, Sparks concluded that pregnancy-related behaviors are most important in offering potential explanations into the racial ethnic disparity observed in preterm births. Her findings were consistent with a report by the CDC that concluded that smoking during pregnancy was also a major risk factor for prematurity, birth defects, and infant death. Those who reach their 25th birthday no longer have to worry about the factors that cause death during infancy and childhood. These young adults are, however, affected by the choices they make and the behaviors they have adopted in the process of reaching adulthood. How many additional years on average can 25-year-old men and women in the U.S. expect to live? This graph shows additional life expectancy for those who are 25 based on the highest level of education completed. The solid bars show life expectancy for men and the shaded bars show life expectancy for women. Once again, we see a consistently greater life expectancy for women than for men at a comparable level of education. We also see another consistent pattern. The higher the level of education one has completed by age 25, the longer one can expect to live beyond age 25. What factors might account for this association between educational attainment before age 25 and additional life expectancy after age 25? Recall from our earlier presentation that the level of education an individual attains is highly predictive of his or her likelihood of becoming a smoker as an adult. Similarly, data from the CDC have identified a significant inverse association between the level of education and the subsequent prevalence of obesity, principally among women. There is also a direct association between level of education attained by age 25 and the subsequent level of physical activity as an adult. Each of these behaviors can be expected to have substantial impacts on physical health throughout adulthood and, as a consequence, on subsequent life expectancy. In order to understand the causes of premature mortality in the U.S., it appears that a stepwise model of associations is most appropriate. The level of education one attains seems clearly to be associated with the health-related behaviors one adopts as an adult. These are in turn associated with premature death and, as a consequence, reduced life expectancy. In considering the causal associations illustrated in this model, I would like you to begin to consider where in the causal chain it would be most effective to intervene so as to reduce premature deaths in the United States, and in so doing prolong life expectancy at all ages. In the next presentation, we will consider many of these same issues, looking at well-being not in terms of mortality rates, but rather in terms of developmental and physical abilities, and in terms of the social relationships one is able to establish and maintain.